It's lovely to meet you after seeing you on the... And if I could get your autograph later, that'd be just lovely. Because when you looked into my eyes, I believed what you said. So just to remind us what we were doing here again is that the National Blood Authority with us and with the CEC are running a series of national seminars on Standard 7. So it's just good to get back to basics. I've learned an enormous amount today, so I think the way you guys organised it, and also those lovely little presents, which we can't afford at the Commission. We would have given you a present, but we just don't have the money, really. But
we didn't tell you. You're helping pay for those, yeah?
Oh, jeez. So what we did was we grouped the day under the 4 criteria in Standard 7. So we talked about governance and systems for blood, documentation, management of blood and blood products, and communication with patients. So if I could just start with Professor Mark Dean, your presentation was absolutely brilliant this morning, and what stays with me the most is what I think everyone in the room wants, is to maximise the benefits and minimise the harm to patients. So I think that's been, you know, probably the best summary. I have said to Lee, though, that as a person who's got no idea about anything but particularly blood, I know that blood can cause adverse events and harm to patients. But to be frank with you, it's not written anywhere. I still don't know what it is. So if I'm a registrar or a senior RMO and I'm sort of making the call about whether the patient needs it, I don't think I've seen written anywhere other than a whole series of other rules and things that are coming in, such as, you know, all the stuff around Standard 7, why I should think twice on behalf of my patient. And I can assure you that the patient and the carer doesn't know. Now, the reason I know this, I know everyone hates N equals 1, but I can give you N equal 2 in my own family. Just in the last 8 weeks, my mother having a blood transfusion. So while it was explained to her what, she's 82, what some of the adverse events were, there really wasn't a deep explanation either to her or me as the carer about maybe we might want to think about this twice. Having said that, she was much better after the blood transfusion. Then with my brother, that a large teaching hospital in Sydney tried to kill unsuccessfully just in the last 3 or 4 weeks, there was no discussion with him at all about his blood transfusion, absolutely none. So I think this issue, where we think we're getting it right most of the time, we probably are, and they're probably outliers, but it's just interesting that at the moment in my own family they're my N equals 2. I love most what you said, that we've sort of gone from thinking about a product, you know, so what are we going to do about PEC cells and albumin and something else, to now what we need to do for patients. And so there's been a cultural shift, because you guys are all the experts in New South Wales and Queensland on this issue. So we've gone to thinking about how would we approach it, rather than from the product, which is the more clinical sort of prescription side of it, to how we'd approach it from a patient's point of view. I loved all of the guidelines you put up, and I think this is half the problem. So we all say, you know, why can't we follow evidence-based guidelines? Why is there only a 50% take-up on evidence at best? Why is there such variation? And many of you presented studies today to prove that exact point. There was a set of data from, I think, Kim from New South Wales showing a 10 to 90% variation in something. And I think it is because we probably have too many guidelines. There's too much for people to read. They're now getting confused, and we have to think about how we can probably get everything on a page, because people aren't going to look unless you're an expert in an area, you're not going to look much past a page. Phil Hoyle did his usual brilliant presentation on the governance and implementation challenges and did his Let 100 Flowers Bloom. But I will remind you that when Ma Zedong used to do that in the villages in China, the exact purpose of letting 100, and it wasn't 1,000, 100 flowers bloom was to find out the dissenters in the village, and after they'd had their say, they used to all disappear. I just thought I'd just share that with you. So the old 100 flowers blooming is never a good analogy, because the ones that said, well, you know, maybe we could look at doing it like this, weren't around much after the committee meeting was held. Natasha's paper was, I thought, absolutely brilliant, because that was real life, implementing that patient blood management system in a very large, complex institution. And I'd just like to congratulate her and her team on what I think is a fantastic piece of work. The guys who did blood wastage probably did my head in the most. So we had Peter and Kim and Leslie. I just never knew it was that complicated. And I was, where's Leslie? Oh, there you go. And I was listening to you about really what is a supply chain issue, and the fact that they've got a senior specialist trying to work through, or we have got a senior specialist trying to work through a simple supply chain issue. So what I'm saying is, in health, we often take it for granted that apart from being absolutely brilliant clinicians and administrators, that we're also brilliant in, say, supply chain, and we're clearly not after listening to your story, and I'll never look at Eskies the same way again, though. Tell you what, it'll be handy for the cricket if I could borrow one of them. Because you can't get a cold beer out there, as you know. And Sally's paper on variation, no, that was with the 10 to 95% variation, the Blood Watch, the brilliant work the CEC's been doing on documented consent. That has really got to make us all worry, hasn't it? I just thought that was a fascinating piece of work. And then we finished with very powerful papers this afternoon with Karen's work, particularly her insights for us around health literacy and informed consent, an area that I feel very strongly about. The longer you've been in the system, the more you see things clearly, and unfortunately I've been in it for too long. And then John, your paper was extremely powerful. For any of us that have been through an experience as a carer, or any of us that have been clinicians, I just thank you for how powerful and how human it was, and how important it is. And I think we generally do realise that when we get a patient, we get a package. So we get a patient, we get a carer, and we get a family. And I think certainly my own experience says that we've changed a lot. You know, I remember ward rounds, this just proves how old I am, at Ramwick on the oncology unit, and women with breast cancer, often the husband was told, and then they'd figure out when they would actually tell the wife. So for those of us who've been around, and that was not, I can see what you're thinking, that was not in 1960, it was in 1980, because he's got that look. So what I've learnt the most from today, from the standards point of view, is once again the complexity of implementation is enormous, isn't it? Something that looks simple on paper, to me, I run around the country saying standard 7's a breeze. How did they get away with it? How did they even get in the national standards? And after hearing that today, I shall never say that again. So there's all the cultural issues. I think keeping up with the evidence is often the hardest part for really busy clinicians, and certainly if they're having trouble keeping up with it, imagine how the patients and the families and the carers have the trouble they have. And I have many friends who are senior clinicians, you know, and they say, if another patient comes into my room with something they've printed off the internet that's not out of a refereed journal, I'll shoot myself. Well, the answer is, yeah, go ahead and shoot yourself and start providing your patients and families with some information that's not going to irritate you, because people are wanting more information. Infrastructure was a big thing, I think, from today. You know, the IT systems, the inventory control, just basic systems that probably in other industries they do exist. I remember Roger Corbett, when he and I first met, we were having a bit of a run-in because he told me that the Children's Hospital at Westmead didn't have enough money. I said, of course it does. And this sort of went backwards and forwards. And because he'd been running Woolworths for years and years and years. And I said, well, we're looking at our supply chain and we're thinking about selling it. And I said, well, you have a look at it, because I always thought people could do our supply chain better than us. It was just becoming more complicated. He said that we hold 1,000 times more product in one hospital than he did in his biggest warehouse. So also a lot of the things we're trying to deal with, a bit like defence and some other areas and child protection, it's just very complicated business that sometimes the business rules are hard to apply. Now, leave it to a midwife. I always say leave it to a midwife. Cheryl Lang, who I think just left, is a midwife who works up in Queensland. And she said, Deb, I've been listening to all this stuff about the paperwork. Is there any way you could get everything on one sheet of paper, a bit like the midwives' data collection? I thought that was very clever. Have any of you ever seen the midwives' data collection? It's really worth having a look at, and maybe we should be thinking about that, because listening to some of that, you've got so many pieces of paper floating around, maybe just one carbonated set could change your lives. I don't know, they're all looking at me. I want to thank you so much to each and every one of you for your commitment to resolve these issues and to meet these challenges. It's just it's just been an incredible privilege to listen to you, and I know that you're doing that because you want things to be right for the patients. Your work is just absolutely incredible, and you're certainly at the cutting edge of it. So I suppose the take-home message is that when we wrote Standard 7, which was done with the National Blood Authority and with, my understanding, hundreds of clinicians, we may not have got it right the first time around, and this is what I'm saying to people all around the country. If we learn over the next few years that we missed something vital, that we had things in that really don't make any difference to patients, then we need to revise that. So the whole time you're looking at that Standard 7, you're stuck with it, unfortunately, for 3 years. Yes, you do have to meet it, so you can't get off the hook. But if we haven't got it right, then we need to know, so when we do the revision in 3 years' time, we can make it more focused or tidy it up. All those standards are just not going to be right on the first cut, even though we did have an enormous amount of clinical input and an enormous amount of input from patients and consumers, but not nearly enough in my view. And I suppose that the take-home message from me is that we shouldn't underestimate the ability of the patients and families and carers to deal with bad news. I know one of the reasons that we're hesitating, to put the list of things up that could happen to you if you have a blood transfusion or a blood product or something like that, is this whole issue that this is a very valuable resource that's donated to us by the community, so that if we were to come out and say that a little bit more and be a little bit, franker about it than what we've been, perhaps, to the same extent we've been around hand washing and cross-infection and giving people the right antibiotics, that could have some effect. My experience is that the community is able to deal with it. They actually can work it through, and on every occasion, even with the size of the health literacy issues we've got, they can work it through. We should never, be so concerned that we don't want to give them the good news with the bad news. So that's just a bit of a take-home message. And we've got all of the, going back to Standard 7, if any of you have got any worries after the meeting, and we have had a lot of people come to us on our little mini stand over there, don't forget there's the Advice Centre. We're going to follow up a lot. We've got about 15 major things that have been raised with us today, which we're certain we can help people with, and all the rest of you are more than welcome to contact us. So I just salute each and every one of you and thank you for a wonderful day. And over to my boyfriend.
Thanks, Deb. I don't have much to add to what Deb's already said. I will thank the speakers, as I have individually. If it wasn't for them, we wouldn't be able to put this symposium on. Today was about you, very much from the National Blood Authority's perspective. We are we are keen to support you as best we can to implement the standards. Our interest, we have a shared interest with the Commission, although the Commission has a wider agenda. Our interest is to reduce wastage and, most of all, improve appropriate use, because that goes directly to actually improving patient outcomes and actually saving patients' lives. So just to reiterate, I started that with that clip, the start of the day, just to set the scene of what this is about. It's very serious. You're the people that can change that, not us in Canberra. We are keen to hear from you, keen to support you in any way you think we can. So in summary, thank you very much for your interest, and we hope to hear from you and talk to you again. And I've been told I also have to, as is the case, there's a feedback survey that's been sent to all registered attendees by email. If you do not receive one and would like to provide feedback, please email us at events@blood.gov.au. Thank you.